Today's eForum is about healthcare for brain tumor patients during COVID-19. And with me in the panel are Associate Professor Dr. David Low from NNI, representing NUH, Prof. Yo Seng Sai and Dr. Vincent Ng, and Dr. Kevin Chua from NCC, and Dr. Enrica Tan. The eForum that we are having right now will be recorded and eventually shared on BTSS platforms so that the information that we have here today would be passed on to patients who are not able to join us today. And also, please recognize that the panelists that are here are representing BTSS medical advisors. The first part will focus on outpatient care. That means the health care that we receive as patients who do not stay in the hospitals. That means we have been discharged and we have regular appointments. And the second part will focus on inpatient care, which means you would be warded in the hospitals. Okay, and I know that we have many questions around it. And to facilitate, I would start by talking about the outpatient care. And right now, I think perhaps it's a good point to talk about what many of us are experiencing as outpatients. For example, several of us have been asked, received a call and asked whether or not we are okay with our appointments being rescheduled. And some appointments have been rescheduled for as long as, like, for myself, like 6 months later. And this has posed a concern to some of our patients because, they wonder whether the suggested rescheduled date would be all right for them because they feel all right, but they worry that subsequently the brain tumor could be growing inside and they don't know. And if symptoms present, it might be a little bit too late. So, I like the doctors to comment about, firstly, how do we decide which outpatient, how do you decide which outpatient care has to be rescheduled? And how long a later date, these patients would be, and why is that so? And, and how patients could better manage their own monitoring to know when they should be going back or asking for an earlier appointment. So these are questions in our minds. And we would like one of you perhaps to start the ball rolling and talk about this.
Okay, I'm happy to start, Melissa. Yeah.
Okay.
So I'll just speak on what is being done in NUH, but I think that's probably the same in the other hospitals as well. Yeah. I think, but even before we come to that, we have to understand the reason behind why we are sort of discouraging patients coming to hospital, outpatients coming to hospital in the first place. Yeah, it's because of the COVID virus. There are patients in almost every public hospital now has COVID patients. So basically it's social distancing. We don't want you to come to hospital if it's not really necessary, because that just increases your chances of getting COVID, because all the hospitals are actually high risk areas in general, right? So that's the fundamental principle. So we've been practicing this, I think, in Singapore for the last 4 months, already, almost 4 months, yeah, since COVID first started. I think there's been certain ramping up. Initially we're just supposed to maybe cut down our clinics by 20%. Now it's cut down by another 30%. So essentially, I think the clinic workload has dropped by, at least in NUH, by about 50% or more, right? Yeah. So of course this worries a lot of patients. So I'll just concentrate on brain tumor patients, right? So I'll divide them into two categories, maybe the new patients with a new referral, as well as those for follow-up, right? So for new referrals, I think brain tumors, even the benign brain tumors, are considered urgent things. Yeah. So in general, I think there will be some senior doctor that would vet all the referrals that are coming in, right? So if it's not something that's urgent, for example, it's back pain from a slip disc or something, then that patient could be seen 6 months from now or something. But if it's a patient with headaches or with a known brain tumor that's coming in, then rest assured that that patient will definitely still be allowed to come to hospital and seek consultation with a neurosurgeon or the neurospecialist or whichever specialist. So I think the public should be reassured that there's no compromise in terms of the care there. Yeah, I mean the urgency. We still give brain tumors top priority, whether it's a benign tumor or a malignant brain tumor. I think for the follow-up patients, it could be a bit different. Yeah. So not every brain tumor is equivalent to the next. So those that require regular follow-up, normally the more malignant brain tumors, you know, if you need to be seen 3 monthly, you will still be given that appointment. Yeah. Many of the benign tumors that are seen once a year and everything's quite stable, then yes, many of those we have postponed their appointments. Yeah. In some cases, patients have come back for their scans. Yeah. And in many brain tumor follow-ups, especially the benign brain tumors, you know, we don't really, the scan is the most important thing. So if the patient's quite well, and they're just coming for follow-up, yearly follow-up scan, and the scans are okay, then we have actually called up the patients to reassure them that the scans are fine, you know, but maybe you don't physically need to come to the hospital to reduce your chances of getting infected by COVID. So we've also done that for some of the follow-up cases. Yeah. So I think the important thing I want to say is that every case is individually seen by a senior neurosurgeon, either the consultant himself or a senior resident who will vet through the entire sort of clinic list. And, you know, we actually have to tediously go through case by case to see whether this patient needs to come or doesn't need to come or can be postponed. So I think there is some reassurance that if you need to be seen, then you will be seen. So and those that really can wait, I think you have to believe your doctor that your case is one that can wait. You know, I think if you still have some reservations or you have some new symptoms that develop and your appointment has been delayed, then you can always make a phone call to the clinic or a respective doctor, and I'm sure all of us would be very happy to see you in the clinic if necessary.
All right. Okay, thank you, Prof. Yeo, for sharing. And is this the same for the pediatrics segment? Maybe Enrica, you'd like to share for KKH, is this the same?
Yes, absolutely. So for us, oncology is still considered essential services. So it's business as usual. So patients who are newly diagnosed undergoing treatment will be prioritized. And on our side, we also have precautionary measures taken at the hospital to make sure that patients who do need to come for appointments or scans or treatments will be in a relatively safe and protected area. So there are stringent screening measures taking place at multiple levels, the time that they enter the hospital compound, before they enter the clinic, and then as well as the ward. And if they have any signs of respiratory symptoms, they will be triaged at a separate area and then decided whether the child still should carry on with the procedure and the treatment as planned. But of course, urgent treatments, for example, antibiotics for neutropenic fevers, that's still considered urgent. So even if they do need to they do have respiratory symptoms, they will be isolated in the isolation ward, and those simple administration of IV antibiotics can still be given. So patients' care is still our priority. So as much as possible, all these things are set to place. With regards to outpatient appointments, though, similarly, our oncology clinics are consultant-based clinics. So the consultant goes through the list and determines whether or not that particular consultation could be postponed. Definitely for patients who have been off treatment for the past 1 to 2 years, they're relatively stable. Usually we would say that they can probably postpone the appointment. The doctor will probably give them a ring, check that the child is well, and then make a decision with the parents to postpone the appointment to a later date. And most parents actually appreciate that and prefer to postpone the appointment.
Yes, that's right. And that's the other thing that's happening. Many brain tumor patients in BTSS have actually mentioned that, you know, they are thinking about postponing their appointment on their own accord. You know, I have an appointment and I'm not very sure whether I should postpone it. So they are the ones thinking about rescheduling it. And although the appointment is still there, so what is your advice, you know, to a patient who is considering such a question, whether they should voluntarily call in and postpone it?
Definitely, if it's just monitoring, like for example, if they are just on surveillance, more than 5 years out, it's quite clear we'll probably easily postpone it to the next 3 to 6 months after the appointment date. But if they are on active surveillance, it's always a question of whether they have symptoms. If they're not sure, there's a clinic hotline that they can call, or they can email to the KK appointment desk, and then we can actually get the physician to call them and to check with the parents with regards to symptoms.
All right.
But if it's for assessment scans, usually it's monthly for the first 1 to 2 years. If it's a malignant brain tumor, we would usually still carry on with it.
All right. Okay. In fact, you know, I have a question from someone here. She says that she has an MRI scan in July, and so far there's no notification from NUH, like exactly the situation I was telling you about. And there's no notification that's to be postponed. So can she assume that she would just proceed as scheduled?
I would presume so, yeah. I think, although truth be told, we don't sometimes look at appointments so far ahead. So we look at, let's say for now, we may look at appointments in June, yeah, you know, because it's May now. So we may or may not be looking at the July appointments yet.
Oh,
so,
I see.
So you may get notice later.
I see. Okay.
Because we don't really know, you see. I mean, if the situation turns out to improve, right? So there's no point us looking 6 months ahead, because we may not have such stringent measures 6 months ahead if the COVID situation improves. So we're just looking at a month or two ahead at the outpatient basis.
Right. You know, I was just thinking that, you know, with so many appointments being rescheduled, there is a possibility of a backlog, in the sense that, you know, when finally restrictions are eased, would it be a situation where you have to catch up with so many MRIs and, you know, so many reviews, that it's going to be yet a longer wait before it finally comes to your turn?
Well, I can speak from the SARS experience. Yeah, I think after SARS was over, I think that time the minister, Mr. Corbyn, Minister for Health, was expecting a huge surge in the outpatient attendances, but somehow it didn't happen. Yeah, so I think it goes to show that maybe a lot of clinic follow-ups are maybe, you know, not really necessary. Like, this is in generic terms, all right? I'm not talking about brain tumor in particular. Yeah. So I think there would be a bit of a surge, but it would not be overwhelming. I think that would be my prediction. Yeah.
Okay. So what would be your advice to patients who are coming in for their regular treatments? Like, you know, they are coming in for their radiotherapy, for example. Perhaps Dr. Kevin Chua, you want to give some advice, you know, about them making their appointments to NCC for their radiotherapy. What would you advise them to do?
So for radiotherapy in general, like Enrica said, you know, this is an essential service. It's business as usual. So we have not seen really a delay in patients who need radiotherapy receiving them. I guess the main advice to give to patients would be, you know, do not be afraid to let your doctor know or to let us know if you're not feeling well. I think, for example, radiotherapy tends to take place over many weeks, and a lot of times, even if we have to take some precautions, we have to, interrupt the treatment for 1 or 2 days. Potentially right now with the circuit breaker in place, we do have more stringent screening procedures. So usually even if that happens, we can, for the most part, make up for these treatments by treating you over the weekend, or even, sometimes if we really need to, treat you twice a day as well. So I mean the key here is that sound out if you're not feeling well. Let us know, and let us make the call. Leave the responsibility of of screening and deciding whether you're fit to continue to us.
I see. Okay, so let's follow up on what you just shared. Assuming if the patient is not feeling well and they're scheduled for their radiotherapy, and we know that, for brain tumor patients, you shouldn't miss your radiotherapy sessions, but they are not well. So what would be the likely cost of action or management for these kinds of patients?
So, the guidelines are changing every day, but based on the latest guidelines, basically dealing with a very vulnerable population in general, the general advice would be that if you have any acute respiratory symptoms, so these can be as mild as sore throat or runny nose. I mean, the truth is we really don't know with COVID. If that's the situation, I think it would actually help if you ring up the clinic or the treatment center and just let them know that you have these symptoms. And then what we would usually advise is if it's a new thing, if it's a new onset of these symptoms. I mean, a lot of times the challenging thing for us would be that some of these could actually be a side effect of the treatment itself. It actually attributed to the radiation, but I think again it goes back to the point of sort of dealing with a more vulnerable population. We do err on the side of caution. So if you sound out early, we will direct you to seek help. And right now the guideline would require a swab. And if it's negative, you can actually still, usually you have a 5-day MC where you are supposed to stay home, but during that period, at least, speaking for NCC, you can still turn up for your treatment, provided the swab is negative. The other situation is if you don't know you're unwell, you turn up at the clinic or at the radiation facility, and it's picked up that you have a little bit of a sore throat. And then what we would do is we would direct you to appropriate facilities that we've already set up. In NCC, we actually have an isolation area where you can then proceed to for your screening and swabs if necessary. And then again, we will advise you to stay at home for a day or two, wait for the swab results, and if it's negative, then we will restart your treatment again.
Okay, right. But it looks as if as long as it's negative, it's still business as usual or treatment as usual for our patients, perhaps with a little bit of delay. But this question on a lot of our minds is that what happens when a brain tumor patient gets COVID? Is it going to be worse for us compared to the regular people? Maybe David, you would like to respond to this?
I think that it's not a simple question to answer, because I think it depends on each individual brain tumor patient, where you are on the timeline in terms of whether you were just diagnosed, you're waiting for an operation, you're undergoing chemotherapy, or you are on a remission and a follow-up stage. So I guess if you have finished your treatment, you're in remission, it's a benign tumor, you're just on regular follow-up, having COVID infection is probably similar to anyone in the general population. The risk of it being more complicated, again, depends on the those existing risk factors we know, age, having other medical problems, and so on. Now, if you are a patient who is newly diagnosed requiring surgery, there are protocols in place where surgery will still proceed, where doctors would take the necessary precautions because this is deemed as emergency, life-saving surgery. So surgery can and is still proceeding for patients with brain tumors. Of course, we've not yet, at least I haven't currently encountered a patient who has active COVID with a brain tumor. But the systems are in place if necessary for life-saving surgery to be carried out. Then moving on to the group that is undergoing active treatment, I'll probably leave the oncologists to comment on potential issues that may arise if they are undergoing chemotherapy and having COVID. But as far as from the surgical standpoint, COVID is a very new disease. We don't even know the spectrum of potential complications, but certainly we would have to observe them carefully for any related complications pertaining to the brain tumor and the nervous system and so on.
Okay, thank you, Dr. Loh. And perhaps from the chemo patient's point of view, what impact would COVID make on patients who are undergoing chemotherapy and then later radiotherapy?
Maybe I'll start first.
Yes.
Thankfully, even on the international front, we don't see COVID particularly targeting patients who are on chemotherapy. So that's good to know. But the postulation is that given the lowered immunity during the time of chemotherapy, I guess we are concerned that they will be highly vulnerable and may not be able to fight off the infection as well as someone with an intact immunity. So definitely we are advising all patients to take their own precautions, even for the caregivers as well who accompany them for the visits and the hospital stay. And precisely because of that, we also want to keep our wards clean and safe, and therefore the stringent screening measures, and we ask that patients and caregivers to please report accurately and truthfully, because we really just want to protect everyone, and you would appreciate if a fellow patient does it for you as well.
Okay, yes, Enrica, thanks for sharing that. And I actually have an experience shared with me from this morning, and this caregiver saying that his family member was undergoing chemotherapy and in the hospital, and caregivers are not allowed. So what happened was that his family member suddenly had a strong reaction to the drug, and she couldn't even press the call bell, and she had like difficulty breathing, and she couldn't even call the call bell. And fortunately there was a nurse nearby, and she alerted the nurse to get some attention for help. And the question is right now is like, oh goodness me, if caregivers are not allowed and then the patient is on their own and something happens, and it's understandable that hospitals may not have enough staff to pay careful attention to everyone who's doing their chemo, you see. So what are safeguards that have been put in place, or is this a gap that we eventually would have to think about solutions for?
Maybe I can help answer. Not pertaining specifically to patients undergoing chemotherapy, but the case is for any patient currently admitted in the hospital. Yes, the rules are strict that if you are in the normal wards, you will not be allowed any visitors. Any communication between doctors and families can be arranged separately, either teleconference or we can meet them at a separate location outside of the ward. In terms of the concern about adequate staffing for care, so yes, a lot of doctors and nurses have been reassigned and deployed to critical areas, but in high-risk specialties, patients undergoing chemotherapy, post-operative patients, the nursing ratio and the care is still maintained at the normal, at what is required to ensure that there is proper care given. also, in addition to that, actually, the number of elective surgeries and patients coming into the emergency department are less now. So actually, the hospitals are actually a lot quieter. Patients who need to be in hospital have the attention from the amount of nursing and doctors in hospital to look after them. So I don't think that is too much of a major concern. Yeah.
Okay, thank you, David, for your response. And Kevin, let's go back to the impact of COVID-19, potential impact of COVID-19 on brain tumor patients who are undergoing radiotherapy.
I think the implications, like what everyone has brought up before, I think there's a lot about COVID and its implications that we still are learning every day. We do generally think of any tumor patient, any cancer patient, or any patient who's undergoing active treatment as being, somewhat immunocompromised, and therefore we do, manage this group of patients more carefully. I think when it comes to radiation treatments, that is no different. From the available literature so far, some of the associations between incidence of COVID and radiation treatment per se seems to be sort of more pertaining to the lung radiotherapy patients and not so much the ones who are undergoing brain radiotherapy. So in that regard, I guess, we know that it's not a risk that applies to all per se. I would say that, if you're undergoing brain radiotherapy, and currently there is no data or no good evidence that if you do get COVID, it's going to hit you worse. And, again, it goes back to my point earlier. If you feel unwell, it's actually more important that you sound out and that we investigate you appropriately.
All right, thank you. And again, I want to do a summary and welcome those of you who just joined us. And in the past 20 minutes or so, we have spoken about the impact of COVID-19 on brain tumor patients, whether they are going for surgeries, for oncology, chemo, and also radiotherapy. There is no known impact on brain tumor patients that it would be worse for us. It's about the same as everyone else. It depends on individual factors. And the key thing is to note that hospitals are doing their best in taking the highest precautions to ensure that everyone is safe. And again, hospitals are also open to patients calling in. If you have symptoms of flu and you're not very sure, you call in and they will make an assessment as to how your case will be managed from there. So personally, for myself, I also understand that there are lots of checkpoints in the hospitals. Almost every department requires you to do a check-in in terms of thermometer, temperature checking, as well as, scanning your safe entry. So I've heard that it has changed from manual paper and pen to just doing a barcode scan right now. So good on the hospitals for doing that. And it's just a practical tip from me to you that you should go to the hospitals like 30 minutes before the appointment time to clear the necessary checks. That's the thing that's now different. In addition to it, you will be pleasantly delighted that the waiting time to see doctors is a lot shorter. And we hope that this positive aspect will continue after COVID circuit breaker measures are eased. So whilst we'll take a short interlude right now by having a poll for people who have just joined us. BTSS would like to know how you feel. Those of us, we can't see you, we can't hear you, but we are giving you an opportunity to express your opinion. So I'm launching a poll right now. All right, to all of you. So we like to understand what are your main concerns during the circuit breaker period. So please take anyone that's relevant to you so that BTSS has information about what we can do to address your needs. Okay. It seems that getting infected is still a lack of access to doctors as well. It seems to be a very high area of concern. All right, so far I've got 7 entries. I have more participants than 7, so come on, pull in your concerns. I'm just giving a few more seconds for the shy ones to turn in their poll. Don't worry, it's anonymous, so I won't know your name. Okay, so let's end the polling and have a quick look at the results. Right, can you see the results now? So top on the list is the concern of getting infected. And the second biggest area of concern is really the lack of access to doctors. And it seems like there is equal concern about the brain tumor condition, how it is showing and affecting the patient right now, and loneliness seems to be an issue too. So talking about access to doctors, I'd like us to move to an area that is emerging that's very interesting. It's about teleconsultations, right? And which of you, I noticed that Prof. Yo as well as Vincent has got their videos off, but I would like to know, you know, which perhaps share your experience about telemedicine. What do the patients need to learn to do to make a teleconsultation more impactful, especially with patients who like have brain tumor conditions, you know, and perhaps they are not very good in the languages or not very technically savvy. You know, what would be your advice to them if telemedicine or teleconsultation is the best option for them?
Okay, maybe I can answer it.
Okay.
Yeah, so telemedicine or teleconsultation at the moment, at least in NUH, we have not kick-started for brain tumor patients. We have started it for some other more general conditions like high blood pressure, diabetes management. And the reason for that is several. I mean, one is, of course, in brain tumor patients, the symptoms and the signs can be a lot more complex than a simple high blood pressure or diabetes patient. And secondly, from an official perspective, ministry's perspective, this conditions has not been sanctioned just yet, you know, for official teleconferencing. Regardless, we have had, you know, informal consults. This can be through emails or through phone calls, rarely through video calls. But personally, I've entertained a few calls from patients and families, parents that have called in directly with some specific questions with regards to any changes in their symptoms, or some with regards to their MRI scan findings as well. So that can be done on a less official basis. I think moving forward, and we are actually developing this for patients, not so much for first visit patients, because for the first visit and a newly diagnosed patients, it's prudent for us to actually see you face to face. And I think it's also prudent for us to actually do a proper examination. And this can only be done on a physical visit. But for the follow-up patients, we are developing a platform for us to have a teleconsult for patients who have benign tumors, smaller tumors for that matter, and on longer term follow-up. So I think with time, we are hoping to develop this, and I think in an ideal state, it should be a video conference like teleconsult, so that we could also, at the same time, see some of the possible signs that may manifest if the tumor does grow, for example, and also to have more personalized feedback from you as well. But this is something that we are developing as we go along.
Okay. What
I think
about,
I want to add
yes.
that two issues about this. I think telemedicine is also being already done, I think, in GP practices and all that. So I think two issues. One is insurance payment. Yeah, so that's one bugbear, I think. So I think we have to work out this problem about whether the insurance companies will reimburse for visits, and this may matter to some patients. And secondly, the medical legal framework also has to be put in place. I mean, it's not the same. Telemedicine consult is not the same as a physical visit. So if something is missed, for example, what are the medical legal implications? So I think this also has to be worked out before we go any further.
All right. Thank you. That's a very insightful piece of information. Yes, and perhaps David, do you know anything about, or can you share NNI's position with regards to teleconsultation and telemedicine?
Yes, so I think what Vincent mentioned is the overarching principles that ministry has for video consults, and it started for more of the conditions like the chronic illnesses. At NNI and I think many other hospitals, we are now starting to look into video consults. And there are issues with, yes, the finance, the charging, billing, and also the medical legal aspects. So at NNI, what we are proceeding to do is, I mean, it's definitely not for first visits. If we decide that this patient can be followed up by video consults, then there is a team of staff that would then get the patient to sign the necessary paperwork, indemnities. They will work with the patient then to identify if they have the necessary IT support at home, and also even then teach them how to operate the system. So how it would work once everything is set up is if the doctor was having a clinic and this next patient was a video consult case, then there is a staff that would bring the laptop in and then get the patient already connected up, and then that saves time and the doctor will proceed with the consult and do the necessary. In terms of medications and prescriptions, that is also something that has to be linked up with the pharmacy, so they can be delivered or in some pill locker or delivered to the house for the patient. So I think we are at the infancy of this process, and if we're talking specifically more for brain tumor patients that are more in the acute phase of treatment, I think it would be wise that they come in and continue follow-up in the clinics, especially if they're on chemotherapy, radiation, or active surgical follow-up. So the maximum benefit, I think, at this point would be really those who are on long-term follow-up, where they're having scans every 6 months to a year. Probably they are the patients that would be benefit most, that they don't have to come into hospitals, and we can deal with them over the tele consult. Yeah.
Okay, thank you. And perhaps Enrica, you want to respond about the practices for KKH?
Yes, so I think actually maybe at least more than a month or two ago, our service had also signed up for the ability to do video conferencing, but definitely it would be difficult to do it for our acute brain tumor patients because it's so important to examine them and to make sure that they are doing well neurologically. So for the acute brain tumor patients, we have not signed up for that, but we are intending to sign it up for the late effect clinic for the neuro-oncology patients, but that has not been started yet. Our pediatric dermatology colleagues have been able to set that up in the infancy stage though, and they managed to work out something with regards to billing as well. Even the video consultations are also charged. But I guess dermatology is probably easier to show the rash on the video and then do a certain from there. So definitely worthwhile looking into for the patients who are on surveillance. But acute patients wise, we would still prefer to see them in person.
Okay, Thank you for sharing that. And over to Kevin for NCC.
So teleconsultations are essentially still something that we are trying to set up in NCC. I think I echo what the considerations are the same throughout, and it's really about doing it in a very risk managed manner. Over at NCC, we have pretty much started for the genetics counseling clinic. That's a place where they are trying it out and sort of learning along the way. But we have not rolled it out to the rest of our patients as well. Specific to radiation, I guess we are also in a unique position where patients do have to turn up for treatments.
Mm-hmm.
And so at least for the patients who are undergoing active treatments, the patients who are most in need of close monitoring, we have still been able to review them physically. So that's been very helpful.
All right. Thank you, doctors. It's very assuring to hear that, you are extremely detailed and mindful about the need to balance seeing the patient personally and deciding what is more suitable for telemedicine. I hear from some of my peers as well that these days you don't even have to pay already. That they visited the clinics and then they find out, oh, I don't need to pay, I can just leave. And of course, they have to follow up with payments through the banking apps and what have you not, you see. But we can see that the whole idea is to make sure that patients do not need to come to the hospitals, and if they are in the hospitals, they do not need to stay longer than they should. Yeah. And I would like to ask this question about how the healthcare professionals are deployed. Sometimes when we have a brain tumor, you imagine all kinds of scenarios, and perhaps the thought that the doctor who's looking after me is also exposed to COVID-19 patients. Is that a possibility? Like the nurses who are looking after me are also involved in looking after COVID-19 patients. So that is an underlying concern that I would like to surface and ask the doctors for your comment.
I'm happy to say that the chance is very low. I think for healthcare workers, I think there are it's debatable whether any of the so-called healthcare workers that have been infected in Singapore so far have really gotten it from the workplace. It's possible, but it's also possible it could be from the community. So I think I've been through SARS, and I've even volunteered to swap the dorms, and I have full trust in PPE. Yeah. So my brother is an infectious disease doctor in NCID. He sees these the sickest of the sick COVID patients in the ICU, and he's been working 4 months there. Yeah, he lives with my mother, who is almost 90. Yeah, and I know he hasn't transferred the bug to her. Yeah, so I think PPE is protective. Of course, if there's a lapse in protocol and so on and so forth, then yes, of course you could get COVID from your doctor. And COVID is very difficult virus. It can spread when a person is asymptomatic. So I think the answer is yes, the risk is there, but I think if healthcare workers take precautions, then the chance of a healthcare worker ending up with COVID is actually very low, provided you stick to the protocols and wear your PPE and don't have lapses. Otherwise, then yes, you could get PPE. We have seen a few COVID patients in NUH neurosurgery, and one of them was not directly even known to be a COVID patient, came to our clinic in the morning, and the afternoon was diagnosed to have COVID. But fortunately, everyone took precautions, and none of the staff, even the junior staff, consultants, even the clinic nurses, none of them turned out to be COVID positive. Yeah. And when it was known to be COVID positive, and we had to see the patient in the ward, in the ward, we gowned fully, and we went to see a known COVID patient, and none of our healthcare workers or neurosurgeons or neurosurgery team, turned out to have COVID. So I think if you take precautions, then the chance is low. But of course, it's not zero. Yeah, it's just if it's so unfortunate that your neurosurgeon has got COVID and you see him in the clinic and you all don't take precautions and then you get it. Of course, it's possible. Yeah.
Mm-hmm. Okay, thank you for responding to that. And I know that, for example, in SNEC, and perhaps in the Sing Health, I don't know whether it's the same for NCC, but I do know that in terms of getting your prescription, everything can be delivered to you. And in fact, free of charge, unless you're not at home when the delivery comes, you will have to pay. So is this also a service for KKH and NUH and NCC and NNI?
Yes, it's available as well.
Okay, do they have to pay for the prescriptions to be delivered?
No, I think it's also free of charge given at these circumstances.
Yeah, unless you're not at home when the delivery comes, I think. Yeah.
Well,
The other thing
everybody's supposed to be at home now.
And it's not just, you don't just have to pay, you also have to pay with the jail term if you're not at home when the delivery comes. And we also noticed that the prescription, instead of the usual 3 months, it's now 1 month. Is there a rationale for that? Or if you have 6 months, they said, oh, okay, I will only give you 3 months. That's what we noticed. So I don't know if any of you would know the rationale for that, we can't take all that we are entitled to normally. It's a smaller batch that we are allowed to get.
And maybe I can respond to that. So essentially, NUH also has this delivery service now for the medications. The main reason why you may be noticing that there is a drop in the supply in terms of you getting 1 month instead of 3 months or 3 months instead of 6 months, the usual 6 months, it's basically due to a international disruption in the supply chain of the medications, delivery of the medications from overseas. So what the hospitals are trying to do is to try to maintain stock, and because of that, and of course we don't know how long this is going to last as well. So in order to maintain the minimum stock that's required in the pharmacies, the general direction is to not oversupply patients as well during this period at least.
I see. Okay, that's interesting. Thank you. And finally, we like to go to this common concern that some families may have about inpatient care, in that sense that the patient has to be warded because she's on active treatment, and not just active treatment, but also undergoing surgery, for example. Because I think the concern seems to be that caregivers are not allowed for patients who are living in the wards or staying in the wards. It would be very hard to be in touch with these patients. And there was a particular case where the patient was very weakened and unable to pick up the phone to call her family. And the family did not hear from the patient for 4 days. And they were worried. They were so worried during these 4 days until finally a nurse who was very sensitive to the patient's condition, found out that she hadn't connected with the family and called the family up using her personal handphone, right? So this is one example that was raised, you see, about the need to prevent caregivers from seeing warded patients as frequently as they wish. And the other one, of course, pertains to critically ill patients. Some are concerned that they want to say their last goodbyes and stuff like that, and they're worried that the days are numbered, and in this situation, not everyone can be there. So what is the hospital's policy regarding this, and will exceptions be made?
I can start off first.
Okay.
I think the general rule from the ministry is where different hospitals have taken direction from So I think if patients are critically ill in the ICU, they are allowed visitors, but the number of visitors obviously have also been cut down, and limited hours as well. If a patient is considered in the palliative care sort of status, they are also, I believe, granted visitors as well. There may be some differences between the hospitals in terms of the number and the visiting times. But certainly for the general ward, unfortunately, the rules are fairly strict. And the fact is that if they are well enough to be in the general ward, then they're not considered, in any way very ill, and therefore, I presumably with IT and technology and all that, they can still contact their families. Of course, the story that you raised, Melissa, is something that's very real, and certainly there may be such occurrences. And I think during this difficult time, I guess it's important that we rely on the team doctors, the nurses, to be acutely aware and sensitive as well, and to try to bridge that gap, and to maintain communication with the family members. Junior doctors can give a phone call, just to give an update more frequently, and so on. And so it's really a two-way thing as well. I guess if a family is concerned and they're not hearing anything, they should certainly try to call the hospital. And I'm sure the hospitals would have a way of directing to the relevant medical care staff to update the family.
Yeah. Thank you, David. And anyone else would like to respond to?
Maybe I'll add in for the pediatric age group patients. Naturally, they would always need a caregiver to be with them at all times. But nowadays, instead of allowing 2 at a time, only 1 is allowed. It has been quite difficult. We understand that there may be caregiver fatigue. So in certain cases whereby the single caregiver is feeling really fatigued or unwell, then we have made decisions to allow them to exchange the designated caregiver. But we understand that's all very difficult times, and so we ask everyone to be patient, as well as we adhere to the government's policies. Definitely in difficult cases, as what David had alluded to, the very ill patients, patients of palliative care, there have been provisions made for sometimes even to parents to be there at the difficult times.
Right. There is a suggestion, saying that for non-ICU inpatients, maybe the ward should set up a computer to allow Zoom meetings like this. So it can be used by all the patients, or brought to the patients who are less able to do this themselves. So yes, and we are open to any comments from Dr. Kevin or Prof. Yeo or Vincent, if you have anything else.
Actually, the nurses have been doing it for some of these patients. I've had a few patients, elderly patients, where they're not so tech savvy, so the nurses have actually been helping them to do it. I think sometimes you have to be firm. Sometimes we can be nice, but we just have to follow the rules. So, I had a patient who was came from a doctor family. She was in the 80s. And the mom knows everybody, also knows my brother, and made a plea that I make an exception so that 4 of them can come to see. I had to unfortunately say no. If I make an exception for them, then everybody will be asking me for a favor. So I said, if you want, you write to DMS and ask for permission. And DMS gives permission, then you can see. But in the end, they are quite happy with just a phone type thing. I think the grandson came back from somewhere and could see the grandma, and she's done well and been able to go home. I think sometimes we have to draw the line somewhere, but I think for those patients who are quite critically ill, it is sad. Yeah, I think there's definitely some negativity in terms of this COVID situation. Close family just cannot come to see a patient that's dying in the ICU, for example. Yeah, so that unfortunately is the compromise we have, and I have to apologize for all the, close family or very ill patients. When this happens, then we just can't can't allow that, unfortunately, in these times. Well, these are exceptional circumstances, exceptional times. I think in most of us, this is the medical crisis of a lifetime. I don't think I will see any. I saw SARS in 2003, and I thought that was bad. This trumps it all. So I think we just have to realize that this is going to occur once in a lifetime, and it's not the normal. But I think I'm very sure we will prevail in Singapore, and things will come back to normal, and then things will be okay again.
Okay, I have a final question, and that's about seeking a second opinion. I am not very sure about what the actual situation is, but my sense is that if you are, let's say, if you are with NUH right now, you won't be able to seek a second opinion in SGH or NNI. Is that true? Because
it depends on what you mean by second opinion. Yeah, if a patient is an outpatient, then that wouldn't be an issue. Yeah, so that's possible. The problem arises in inpatient who's already in the hospital, usually after emergency surgery or something, and the family wants a second opinion, and the patient cannot be transferred, and the doctor from the other hospital cannot come to see the patient for an opinion. But if the family is happy for a remote second opinion, then, or by telemedicine or something, then that's not a problem. But to physically come to see a patient, that's usually not permitted, I would say, by Ministry of Health. They don't want doctors to move from hospital to hospital, except in really extenuating circumstances. I mean, it's not an absolute no, but for a thing like a second opinion, I think it'd be more difficult. If you need a special skill or special technology or something, then yes, sometimes the ministry does make an exception for doctors to cross hospital, but in general, it's strongly discouraged.
Yeah. It seems as if, like, one thing that's definitely happening is that the COVID-19 has stopped all medical tourism. In fact, some of our patients who wish to seek treatment overseas find that they cannot do so right now. So is there any comment or an idea about how this can be made possible for patients who are desperate for an overseas treatment?
I don't think we can answer that specifically, because it really depends on, if you're talking about Singapore family wanting to go somewhere for treatment, for example, proton beam therapy, because we don't have it yet. I think it really depends on the country they want to go to, and each country would have their own rules. So if I talk about Singapore, and let's say Indonesian patients, for example, want to come to Singapore for treatment, then our ministry in general discourages, but doesn't totally forbid. If you can make a case that this patient needs to come here for something that's really quite dire and critical, then you can write to Ministry of Health in Singapore, and I think they can make an exception in certain cases if they really cannot get that therapy in their country and need to come here for treatment.
Okay, that's great. So it looks like, we have covered a full hour of discussion. And I hope that our participants find this interesting. Please leave your feedback in the chat. Tell us how you find this. So I'd like to conclude by sharing what BTSS has been doing for our brain tumor community. Firstly, we have distributed 750 masks to patients, and also thermometers to patients who need them, because they have not been able to access masks in the earlier period of COVID-19. In addition, we have moved our support groups from Singapore General Hospital to Zoom, and we had a meeting just this morning. And apart from it, we are active in counseling. We encourage our patients to connect with the counselors or their trained psychologists on e-meetings or e-sessions, as much as possible, because it's important that our emotional needs are still being met during this period. And of course, we have our WhatsApp group as well. So if you are a brain tumor patient listening in, feel free to connect with us. There are many ways that we can help you, and we certainly can be there for you, together with our medical advisors from BTSS who come from different hospitals. We are glad to be here with you today. Thank you for your valuable time spending it with us. We hope that this session has benefited you.